Hello to everyone and welcome wherever you are joining us from. On behalf of the Europe region of World Physiotherapy, I, as chair, welcome you to this evening's talk. I thank the World Federation of Public Health Associations for the opportunity to include the physiotherapy perspective in this week. We came to this through our partnership with the European Forum for Primary Care, and we're delighted to be part of the Public Health Week, Public Health Matters, Building the New Future. As mentioned by Global Health as the part of the theme for the week, facilitating the sharing of the knowledge, resources and barriers faced by public health professionals globally is key to improving public health in all contexts, and none was more so than dealing with a pandemic and the lessons that we can learn from it. As with all health professionals, we have been greatly impacted by the pandemic. Many contracted the virus, many had family members with COVID and indeed lost family members, and many made great sacrifices in order to provide the physiotherapy treatment. As building resilience is today's theme, I take this opportunity of paying tribute to all of the health professionals across Europe and indeed the globe for the incredible resilience that they have shown in dealing with the challenges of a pandemic, an event was of immense scale that none of us had any experience of, as well as services in ICUs, HDUs, COVID wards, community, transferring private and community services to telehealth almost overnight, dealing with PPE, rehab, people with post-COVID, people with long COVID, vaccinations, becoming vaccinators. These were just some of the aspects that we all had to deal with. And something that I came across when talking to colleagues across the Europe region about how difficult it was for those physiotherapists who had COVID to actually return to the front line and to begin to start treating people with COVID again. And I think what the psychologists called compassion fatigue. And it's really difficult to maintain that high level of compassion for a prolonged period of time. We can all do it for a contained or restricted time, but it's really difficult to do it for a prolonged period. And so we need to know how we can build that resilience for the future. I mean, unfortunately, we actually have to prepare for the next pandemic. And I think that we need to learn the lessons from this one while it's still fresh in our minds, so that we can build back better to deal with the next one. I recently came across a statement that resilience, and I know Rachel is going to talk a bit more about resilience and the word itself, but it's present where there's flexibility. And I think all of the health professionals across the globe were certainly flexible in how they rose to the challenges of this pandemic. And if flexibility enhances resilience, then we now need to learn from that and to harness it for the future. So in this presentation this evening, resilience in physiotherapy practices during COVID-19 pandemic from ICU to long COVID, I thank our speakers in advance. It's from Italy and from the UK. And I encourage you during the talk and afterwards to use the Twitter handle GPWH2022, and indeed to include the Europe region at ER World Physio in your tweets. And just to conclude, I would like to end with a quote from World Public Health, which said, "We may be physically distant from each other, but we are united for the health of the public." And this week is about joining together in the initiative to make public health stronger. thank you to all of you for joining us. And I'd like to hand over now to Maria Busuttil to commence the proceedings. Thank you very much.
Thank you, Esther-Mary, for a nice introduction. We look forward to what is next. Hello to everyone. I am Maria Busuttil. I'm a physiotherapist from Malta, also honored to be an executive committee member of the Europe region of World Physiotherapy. I welcome you all to our event to celebrate Global Public Health Week 2022. During this week, the World Federation of Public Health Association brings together institutions, communities, and public health actors from around the world to recognize the contribution of public health and, most importantly, its workforce. This annual event includes discussion on the best practices and missing gaps fundamental to disease prevention and the promotion of health and well-being. Public health has become very popular lately, probably due to the pandemic, but it has been there for decades in the history of our health system. And let's compare public health to an invisible guardian of our healthcare systems. This pandemic has made the public health field more apparent and appreciated. However, the risk of regression post-pandemic is high. We cannot lose the momentum, and we need to act now to prevent the next pandemic. Making public health visible and understood was a very key step in the past months for emergency preparedness. Facilitating sharing of knowledge, resources, and barriers faced by public health professionals globally is a key to improving public health in all its contexts. We are very lucky to be supporting this amazing initiative on its very first day, the 4th of April, and with a theme that states Public Health Matters, Building the New Future. Throughout the next 5 days, if you follow the account of Global Public Health Week, you will see that there are a lot of initiatives going on. Some of them are virtual, some of them are through social media, and some of them are through in-persona meetings. So I do invite you to collaborate as healthcare professionals or invite your colleagues as well to be able to attend all the events that are present in the coming 5 days. The Europe region of World Physiotherapy has participated onto this initiative, and it has decided to choose the theme of building resilience in COVID-19. Throughout the upcoming webinar, we will be spending together 1.5 hours circa, where the speakers will be presenting physiotherapy practices, both from the physiotherapist perspective and also from a patient perspective. And also, they will give us an overview on the acute care, on the post-acute care recovery, on the rehabilitation, on the long COVID stages, a new phenomenon that we all have heard about in the last months. We will be then continuing on to a panel discussion, whereby we will be asking a bit of salient questions to our speakers. And then we will be lucky enough to have an open discussion between us to be able to present questions from all of you to our distinguished speakers in order to create a very dynamic and proactive discussion. It is important that you move on to sharing the questions in our chat, where our technical staff will be collecting all the information, and then they will be passing it on to me as a moderator to be able to ask the questions through to our speakers. If you feel that you need to interact with our speakers at a later stage in the presentation, feel free to write it on the chat, and our technical team will give you also the faculty of being able to interact with us. We encourage you to promote the session and share your ideas on social media by using the hashtag GPHW2022. Also, to conclude, I wish to inform you actually that the meeting will be recorded and it will be later uploaded on your website and our YouTube channel. So if you want to share it with your colleagues, it will be also available at a later stage. Today, we have planned to start our session by listening to a presentation of one of our Dutch colleagues, who due to unforeseen circumstances couldn't make it today. Her name is Loes van der Valk, and I sent her all my best wishes from here. Therefore, we will be moving on to the next speaker, who is Miss Rachel Moses, and she will be talking to us about resilience and recovery for your physiotherapy community. Rachel is a consultant respiratory physiotherapist, also working in a national leadership role in the National Health Service in England. Rachel, I'll give the virtual floor to you and good luck. Thank you.
Thank you so much. So let's see if I can share my screen here. Okay. Can you all see that okay? Great. Thank you so much. So I'm delighted to be here today to discuss the resilience and recovery for our physiotherapy community and what that might mean. You can see my email on the first slide, so please do email me if you'd like to get in touch afterwards. But as Maria and Esther have both said, please do interact on social media as well, and of course in the question and answer session at the end. Now, I am a respiratory physio and I've been working across critical care and respiratory medicine wards throughout the pandemic. And my area of speciality, if you like, is complex ventilation. So weaning and looking after people on home ventilation. And certainly we've seen huge changes in our practice over the last 2 years, some of which we hope will not continue, some of which we hope will. But what I'm really going to focus on today is some of the lessons learned and how we can never look back and always look forward, especially in terms of sharing of information. Now, this concept resilience, if you're a clinician listening to this talk, or if you're a clinician who thinks about the word resilience, it may have a very negative connotation for you now. And the reason for that is that many clinicians, and indeed anyone really working in healthcare or frontline services over the past 2 years, have been expected to be resilient. And this resilience has been part of a survival strategy forced upon people over the last 2 years. And really the term resilience people don't identify with very well now. And if we think about the dictionary definitions of resilience, this is what you will find if you were to do a Google search, or if you were looking to your dictionary. And if we look at the Cambridge Dictionary, or some of the definitions from psychology, particularly trauma psychology, the term resilience refers to the ability to be happy, successful again after something difficult or bad has happened. Now, the issue with this is that if you aren't resilient, or you don't seem to be resilient, then you have failed. And we find that in this context of resilience and survival, that we find the term being oppressive, and people don't feel like they can be open and honest about their feelings, and if they are starting to not cope or not be resilient. And this can have, of course, a really negative impact on someone's mental and physical health and well-being. So if we think about the concept as resilience, which this is a more psychological based definition, is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant source of stress. This is where we maybe need to focus on the physiotherapy profession and how we have remained resilient across the last 2 years of this pandemic. Now, if we think back to January 2020, at the very start of this pandemic, in some cases it may seem an absolute lifetime away for you, in some it may seem like just yesterday, but predicting the unpredictable was always going to be difficult, but even more so in the context of a global pandemic. There are other events that provide transitional learning and experiences that can help guide us, but it was a very daunting time. And if we go back to this definition of resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant stress, there are many ways we can support resilience within our teams and organisations. Now, for any of you that have heard of the 6 Ps, I believe this is a military acronym, but something I learned or first heard of as I was training to be a British Army medical officer. But these 6 Ps, prior, planning, preparation, prevents poor performance, is something that I really draw upon, and I find is a really good analogy and something which I reference throughout this talk. But we, as much as we have suffered at the hands of the pandemic, we are now, and we're still very much in a pandemic state in many countries, including my own. We can also plan for recovery as part of this and how we can continue to learn. And the most important bit of advice I give to people when we talk about recovery in the midst of crisis is really understanding your teams and understanding what motivates teams, what drives your teams, what inspires your teams, but equally what causes anxieties, fears, and concerns. Because in a crisis, you need trust. And these are the things that will build trust in your team. Knowing the characteristics of people are the foundations of teamwork. And when you have those foundations built on trust and understanding, that will build a team or create a team that has stability, security, and strength over one that can become fragmented and fragile easily. And when you know the individuals within your team and you know them well, you then have a shared vision and you have collective tasks. And we know in a rapidly changing environment, such as in crisis or pandemic times, these dimensions can change very quickly, but they are all interconnected. And what anyone will know who has practiced crisis leadership or has read about crisis leadership is that crisis itself does not build character, it reveals it. So one of the things we need to recognise as a success of this terrible pandemic, and one which has huge benefit for global health, was the sharing of experiences and learning from each other as key opinion leaders and experts in our field. From a personal experience, I decided very early on I did not agree with Public Health England guidance on aerosol generating procedures. And I decided to write my own local guidelines back in February 2020. And these originally were local guidelines used for my organisation to protect physiotherapists and other staff within my hospital. But when the pandemic was declared in March, it meant I could share them readily across the internet. And that is something that I have never seen before on this scale. People sharing their own work without a paywall, without anything in return, and also to support other countries or teams that might not have the resource that certainly we have in the UK. And it wasn't just about our guidelines, it was about things we were doing to support our physiotherapy workforce. That might be from health and well-being, that might be from how we can nurture our teams, but also how we deliver practical skills and treatment. And of course, this is when the global physiotherapy team came together. And I still feel really blessed to be part of an incredible group of international clinicians who came together to write a guideline, a peer-reviewed, evidence-based as much as we could guideline that was published on the 23rd of March 2020. And to achieve that in such a short period of time is credit to all the authors you can see on this screen. And not only that, we then went on to host some free online rapid learning and sharing sessions via YouTube to help ensure we had as much reach as possible. And for anyone that wants to access any of these, please do, you can just go onto this YouTube channel and watch any of the COVID series. They are still on there. So as part of crisis leadership, a lot of it is around planning, priority planning. A lot of it is around knowing our teams and our key influencers. Who is going to make our decisions? We then need to actively listen. We then need a feedback mechanism that we know as leaders if we are doing the right thing. Are our messages getting to the right people? Do people have confidence in what is happening? Do people feel like they're well communicated to? If not, how can we change and adapt? There needs to always be time for reflection and debrief, even in the most chaotic of environments, because this is what helps give clarity and control. And of course, the shared learning is part of that. That isn't just our successes, but also the things that haven't went right, so people don't make the same mistakes as what you have made. And for this to happen, for this to truly happen, we need to move away from a command and control model where leadership and management is intertwined, where people are given the autonomy to make decisions that they feel safe to make. Gone are the days of micromanagement or people being fearful of making decisions because we just cannot manage in that complexity mindset in a crisis. And of course, I don't need to tell you much about physiotherapy interventions during the pandemic, but what I will say is the importance of our role in secretion management, airway clearance, ventilatory reading, tracheostomy management, positioning, and of course proning, and rehabilitation in both the acute and long-term phase of COVID-19 infection has never been more widely known. This is something that we can never let the world forget. And also, as part of our resilience, how we have constantly evolved during the pandemic. And I, for one, have never been prouder to be a physiotherapist than I have been now. But our approach to recovery is critical. With the longer term effects of COVID-19 on both our personal health and well-being, that of our colleagues, patients and public, our health and care structures are stretched more than ever before. However, there is a lot we have control over. Ensuring we remain compassionate and kind in our everyday interactions with people. And when we talk about compassion and compassionate leadership, this means listening with fascination, in the words of Professor West, listening with intent, listening with curiosity, really trying to understand people and how they're feeling, being empathetic but not sympathetic, and always showing support. We need to have collective shared values as teams and as professional groups. And we always need to take time for reflection, allowing space for debriefs. This is something that we just can't ever stop doing. And this constant learning cycle where we're asking for feedback and we're sharing what we've learned, successes and the things that haven't went as well as we have expected. And this is something that we should share globally. We should have free access to research and educational materials, and this will help reduce the huge healthcare inequalities that COVID has further highlighted, and making sure that our profession is truly inclusive to everyone that needs us. And of course, making sure at this point all of the learning is documented for future pandemics, so the next generations are properly prepared like we never were. So I want to say a big thank you to everyone who's listening for their continued hard work and dedication. I'm sure it's a really tough place for you all to be right now, but together collectively, I really do believe we can share some of the strengths that we've all done together over the last 2 years. Thank you very much.
Thank you, Rachel. for a very insightful presentation. I have already a couple of questions that perhaps you could discuss later. Now I wish to introduce a dear colleague of mine from Italy, Miss Loredana. Loredana Gigli will be presenting to us a patient case physiotherapy report during COVID-19 pandemic. Loredana is a head of rehabilitation professionals in a large public health company based in Rome. She's a lecturer at BSc degree in physiotherapy and MSc in rehabilitation. She is also a secretary of Rome Physiotherapists Order, a member of the Italian Association of Physiotherapists, a member of the Professional Practice Working Group, and of Europe Region World Physiotherapy. Loredana, the floor is all yours. We look forward to listen what's next. Thank you.
Thank you, Maria, for your presentation. I think it's enough for me. Too much thing to do. Just a minute to, can you see my screen? Give me a feedback, please. Can you see my screen?
Yes, we can.
Okay. Good evening to everyone. And thank you to Esther-Mary, thank you to Maria, and to World Physiotherapy Europe region, which I am proud part of. This evening is very important. I will present you a brief case report about a patient in our facilities. We are concerning about long COVID, and we are working on this syndrome starting from the last year. So I will speak about that. First of all, let me introduce my great, fantastic team. These are a group of excellent physiotherapists, speech therapists, occupational therapists. We have two pictures because we have some difficulty to be together all in the same time, in the same place. So I put two pictures to represent all of them. They share with me passion and dedication to our work. And in particular, between them, we have Marco, that is also with us this evening, Gloria, Daniele, Giovanna, che è di qua, e Alice, that work in particular in this sector of the long COVID patients rehabilitation. I will speak on their behalf, but I want to point out that they are those who work hard every day to deliver high quality rehabilitation to our patients. I am only their proud head. So let's start. Every time I speak about COVID and rehabilitation, I like to quote this sentence by Karen Middleton, because it represents and fits perfectly what is the task of healthcare services and rehabilitation in particular, to contribute to the incredible challenge we faced in the last 2 years, and we are still facing, unfortunately. Probably, I think, we were, among the health professionals, the first to perceive that the acute infection due to SARS-CoV-2 could have caused long-term dysfunction and impairments, and prepared from the start to work on these issues. The marathon that Karen quoted has a name, and it is the long COVID syndrome. What is long COVID syndrome? Formally, the condition is called post-COVID syndrome, but even the official definition is fluid because the knowledge of its details is still evolving, is a work is still going on. Britain's National Institute for Health and Care Excellence, for example, defines PCS as signs and symptoms that develop during and after an infection consistent with COVID-19, continue for more than 12 weeks, and are not explained by an alternative diagnosis. In this table, you can see some of the symptoms detected in the patients suffering from long COVID. These symptoms are not exhaustive because we can have many, many others, but are the most common, and some of them are persistent, like you can see fatigue, for example, cough, headache, and so on. And we can find them after 12 weeks from infection. Another thing to say is that long COVID, the syndrome, is not related to the severity of acute infection. In fact, people with mild COVID, non-hospitalized, often are those with more persistent symptoms. Broadly speaking, there are three types of long COVID patients, if we can say so. The first are characterized by exercise intolerance, meaning they feel out of breath and exhausted from even small tasks involving physical activity. The second are characterized by cognitive complaints in the form of brain fog and memory problems. Brain fog is a word, a sentence that became so common in our language, especially in Italy, I think. The third type of patients suffering from long COVID are characterized by problems with the autonomic nervous system. And by far, these symptoms are the most debilitating. So we can conclude that if we rehabilitate, we can be able to rehabilitate this kind of symptoms, we can often make the biggest impact in people's lives. Based on these patterns of symptoms and based on various laboratory tests of long COVID patients, researchers are focusing on three possible biological explanations, because they asked why long COVID, why these symptoms go on for such a long time. One of these explanation, this biological explanation, is that long COVID can be a persistent viral infection. The second is that is an autoimmune disorder, and the third is that it is a consequence of tissue damage caused by inflammation during the initial and acute infection. According to the first of these hypotheses, some patients never clear the virus completely. They are no more infectious, so it could be that they harbor some altered form of the pathogen which is not replicating and is thus undetectable by the standard test for SARS-CoV-2. But it is nevertheless making some viral product that their bodies are trying to fight off. This sort of thing is known to occur with other viruses, as we know, including, for example, measles, dengue, and Ebola, that are RNA viruses. They are particularly prone to this phenomenon. The second hypothesized mechanism for long COVID is that there is an autoimmune disease, and all that the virus, though gone, has caused something to the immune system, which now attack some of the body's own tissues. A growing body of evidence backs this idea too. The third hypothesis, and it is the most commonly said, inflammation, holds that the fight put up by the body against the acute illness causes irreparable collateral damage. This often happens during a viral infection, but it could be particularly likely with COVID-19. Out of control inflammation caused by cytokines is a hallmark of the illness. Studies intended to investigate each of these possibilities are still underway. But these three theories are not mutually exclusive. Indeed, most researchers agree that long COVID is probably an umbrella term which embraces several conditions with different causes. If we can be able to determine these, this will help both with development of treatments and with their prescription. If, for example, persistent viral infection turns out to be a cause, the search will be on for suitable antiviral drugs. Treatment would consist either of a defined course of medication that clears the virus completely, or of drugs that people take routinely to keep the virus at bay. There is a clue, evidence that some of those with long COVID have felt dramatically better after a COVID-19 vaccination. But the relief tends to be temporary. Nobody knows why, anyway. One possibility is that the reared up immune system by the vaccination alleviates their symptoms for a time, and also it could be a placebo effect. Anyway, we can consider it. One only thing we know for sure. At the moment, the possible treatment is rehabilitation that impacts on functional disorders that are the most important, that refers the patient with long COVID. But we ask, which approach in these patients? And so on June 17th, 2021, the World Physiotherapy launched its briefing paper on safe rehabilitation approaches for people living with long COVID. And so my staff and I started to work on a facility for those patients coming to our attention. The main recommendation from this paper can be summarized, as you can see in the slide. That is, the best approach should be gradual, individualized, and based on subjective tolerance of the activity. This is the brochure we created to inform people about our clinic. So in June 2021, we started to receive patients with long COVID syndrome in our center of rehabilitation. Besides the specific individual assessment and tailored program of rehabilitation, we decided to give relevance to the education and self-empowerment of the patient, creating a booklet that could help them to manage the symptoms also at home. This booklet, this one, contains advices for the activity daily living, exercise instruction, and some other advices useful for our patients. It was, I highlighted, a great teamwork with contribution of the entire staff of our facility, including occupational therapists, nutrition, dietitian, doctors, and so on. Just to give an example of this kind of problem, we here report the observation of a patient, female, 74 years old, who started the rehabilitation program on July 2021 after a brief hospitalization and a mild COVID-19. This was his diagnosis: COVID-19 pneumonia consequences, lung sarcoidosis, high blood pressure, type 2 diabetes, dyslipidemia, and psoriasis. She had 2 hours per week of physiotherapy. The assessment was standardized, consisting the short physical performance battery, 6-minute walking test, and the recommendation to the patient to write a diary on a daily basis, in which she had to note every activity and the related reaction, as for example, breathlessness, fatigue, and every kind of reaction to the physical activity. The most impressive result starting at the starting assessment, the first assessment was the 6-minute walking test that stopped after 2 minutes because the oxygen saturation went down to 86%. This was the physiotherapy program that our patient followed and included for her respiratory exercises, muscle strengthening exercises, static and dynamic balance improvement exercise. Anyway, this is the program for all our patients, but they are individualized for every patient based upon the assessment results. After 8 weeks and about 15 sessions, the patient was able to walk for 191 meters about, and the oxygen saturation was at 97% all along the test. Also, the other measurements showed an improvement, and the diary reported that her ADL was carried out without need to stop often, like in the first times of the rehabilitation program. After further 4 weeks of physiotherapy, the patient was able to walk for 200 meters about with a good oxygen saturation. And this saturation was good also both in during physical activity that during rest. She reported to feel much better in terms of muscle strength and breath, and her daily life was almost returned to normality, just like before the infection. In all our patients, this kind of patients, we observed a remarkable improvement in physical performance, so the team are confident that the effect is real. Unfortunately, our activities in our clinic, had to be suspended several times due to the subsequent pandemic outbreaks that involved many in the staff, Esther-Mary knows, and didn't consent to receive patients for almost 3 months. So we do not have further data and sufficient observations, but we recently started again, so we are confident to collect enough data to confirm the effectiveness of the program and to continue work on it. We are still working on it. It's a work in progress. But it has to be said that even with appropriate healthcare, many of those who have long COVID will continue to struggle in their daily lives. A survey in Britain, as you can see in this slide, found that the illness affected the ability to work of 80% of those suffering from it, and about 40% said it affected their ability to care for others. All this suggests that post-viral syndromes on this scale affect not only those who are experiencing them directly, they also have serious consequences for everyone else, because we have problems to return to work, so ability to work, family life, ability to care for dependents, for example, finances, because if you can't return to your work, probably you have finance problems. Meanwhile, we go on, and as we now have in our staff also 2 speech therapists, we included in the initial assessment different outcome measures about dysphonia, swallow, and cognitive impairment. It is an important point, as the research is reporting great concern about the future implication of this kind of impairment and the long-term consequences on neurological system, as we can see in this article. The most impressive sentence in this article, in this abstract of the article, is that the hippocampus appears to be particularly vulnerable to coronavirus infections, thus increasing the probability of post-infection memory impairment and acceleration of neurodegenerative disorders such as Alzheimer's disease. What we can expect in the future after this pandemic. So we have to pay many attention to this. And so with my staff, we are observing the phenomenon and we will continue working on it. Thank you to my staff, to my team. They are great, a great team. And I thank you for your kind attention from Italy.
Thank you very much, Loredana. A very interesting presentation. It seems like you are capturing very nicely the sprouts within this pandemic with regards to how physios can help their patients.
Yes.
And always looking at the skills that we have with regards to our specific diagnosis, our specific treatment, coming through a very detailed assessment that we usually do. Now, two brief questions to both of you. I would continue on you, Loredana.
Yes.
So just to give us, some valuable input from your experience with long COVID patients. With regards to functional recovery, also keeping in mind the cognitive element that you have just mentioned, did you observe any difference from other patients? And also, do you think that there is a relationship between the outcome of their functional recovery and their previous severity of the infection? So to make myself clear, if the infection is bigger, do they have less recovery with regards to functional and cognitive with more residual impairments? Just let us know a bit what your thoughts are about, this element. Thank you.
First of all, I said, if I well understood your questions, there is no difference between severe, mild, or moderate or light COVID-19. But about the cognitive impairment, can better answer Marco between the relationships within cognitive impairment and recovery, functional recovery. Marco.
Yes, please, Marco,
Yes,
to go ahead. A brief introduction. Marco is a colleague of Loredana, and he has been helping her to present this part for today's seminar. So, Marco, the floor is yours. Would be delighted to hear your opinion about this question. Thank you.
Good evening, everyone. First of all, thank you, Esther-Mary. Thank you, Maria, for the invitation, and a special hug for Ukraine friends. We know that all long COVID patients have some kind of cognitive impairment or dysfunction, like lack of memory and concentration. And this occurs mostly in younger patients than in older. Literature reports us that a severe COVID-19 is related to an important memory impairment, and in general in a bad cognitive profile, a worsened cognitive profile. So it seems that symptoms like fatigue are negative predictors for cognitive performance, with a high risk of an important memory impairments in a long term. And so with our patient, we try to apply a cognitive screen with follow-up after 6 months or 12 months to monitor the onset of these mental impairments, cognitive impairments. Let me quote the axioms by Paul Watzlawick, because also in this patient is more important the role of communication and the relationship because of these cognitive impairments. Thank you, everyone, and looking forward to meet you in person.
Thank you, Marco.
Loredana,
Yes.
Would you like to add something else?
Yes, I want to point out what Marco said with our work, how I was saying before. that is very interesting, the evolution of our work, because we are observing some phenomenon on our patients. First of all, our patients are, everyone is different from the other, everyone. Also, if they have the same infection, the same kind of infection, they were hospitalized, but everyone is totally different from the other. And the interesting is the observation of these patients that makes us asking questions all along our work. And so we are trying to have explanations about what you asked. So we are working on it, and sure we'll let you know about our funding.
Thank you very much.
Thank you.
My second question goes out to Rachel. So, Rachel, you have mentioned resilience and survival and how one can be interpreted as the other. We know that the last 2 years have changed every one of us, the patients, the population, the healthcare professionals. Now, as a person who has been a frontliner, and we know that you have been a very important change agent as well to your country in reaction to this pandemic, what future opportunities do you recognize? Do you wish that are even implemented after these stages, also to be prepared for future pandemics? And these opportunities, can you perhaps, describe them to us from the education sector, the policy sector, the clinical sector? What do you think needs to be changed, and what opportunities we have, captured post-pandemic? Thank you.
Wow, so that's quite a question. If I start with workforce, so I think we have a workforce crisis globally in terms of the number of physiotherapists we have available. And one of the things about policy making and workforce numbers is you can ask for, say, in critical care, for one physiotherapist for 4 critical care beds. You could ask for 1 physiotherapist per respiratory ward, but that only adds value if you have the numbers of physiotherapists then to be able to, go into those roles. So one of the things we've learned during the pandemic is what our workforce needs are based on the roles or the jobs we're commissioned to do. So you can translate this across any speciality, but obviously my speciality is respiratory. So we have a much better idea now of the numbers of respiratory physios we need in critical care units, on respiratory wards, in the emergency departments, and in the community. And that's not just providing acute care, that's providing rehabilitation care. So I think we're much better informed about our workforce needs. The second thing is our flexibility to work across traditional boundaries. One of the things we have become victim to in physiotherapy is specializing. And in the pandemic, we needed a lot of generalist skills. And I have to say, in respiratory medicine, we are the specialist generalists. That's not to discredit any of the other physiotherapy professions, but in acute medicine, we are often the people that can't say no. So if someone doesn't have a broken bone, the orthopedic physios will say, no, we can't treat them, or we don't need to treat them. And I think there's something about this pandemic about people keeping their general skills. And that might be in respiratory management. In the UK, we have on-call rotas. So physiotherapists work 24 hours a day. And that is one way. Our more junior physiotherapists, or those in more less specialist roles, can stay skilled, but also in terms of rehabilitation as well. So I think there's something we need to learn from that about not losing our general our physiotherapy rehabilitation skills. I think the third thing is understanding how we plan for a pandemic, as I mentioned in my talk. So one of the things we've started to do, but not so much, and I myself need to do this, is write our learning down and get it published and capture it now. And it's not just about physiotherapists, I have to say, it's about how we work as part of an allied health professional team, because we've seen the coming together of allied health professionals, dietitians, speech and language therapists, psychologists, and how we work together in both normal times or non-pandemic times and during pandemic times. So we need to capture that. And then the final thing for me is celebrating what we do and doing that more effectively. So one of the things I started to do 2 or 3 years ago, which I know will probably a bit longer, I know a lot of people do, is using social media, is using the internet, is global communities where you can share your successes, because that will add influence to the people of power and the people who have money to fund our roles. So it's how we can use lots of different avenues of influence to help share the power of the physiotherapy profession. And we cannot be shy about that. And some of the great physiotherapy leaders, are very good at that. And that every opportunity I take, I'm sure it's the same for you all, you will tell people the power and potential of physiotherapy. So I hope that answers your question.
Yes, it surely does. A lot of things to think about. I think from the celebrative perspective, we also need to be able to accept that we might celebrate in different ways than we used to do before, and start acknowledging it as our celebrative measure, not keep on thinking what used to be done before. Perhaps going through that transition is very important for us as professionals as well. Something that I picked from what you said as well was the actual how to react to for future pandemics, and I feel that what is taught in the disaster management modules here might apply now to all of us, because before it was used for only specific higher managerial roles within our health sector, and perhaps it could become even an undergraduate credit for all of us to start learning about what should be done in case of pandemics or national disasters, which we have been all acknowledging further through the pandemic experiences that we all have. So thank you, Rachel, for that. I'll move on to Loredana as well. Loredana, something that I remember I picked from one of the celebrations that we had, Rachel, last year for World Physiotherapy Day, is that the Italians call long COVID il sindrome di COVID syndrome, which I would absolutely pick as, as a direct translation, and perhaps as physios we could start using it as a specific physiotherapeutic diagnosis, the difference between cerebrovascular accident and where we go with hemiparesis and hemiplegia and all the details on the movement side. So the syndrome, COVID syndrome, I wish that we could pick it up and have future thoughts about it.
Yes, I remember we talk about it, about this word that it hits you so
it
much.
Hits me so much. I speak Italian, so it was imprinted. Something that you mentioned, Loredana, was a challenge when the health workforce gets ill. Probably all of us have experiences, you start getting very dull from the inside, you say, oh my God, it's happening again. So how do you see this side of the pandemic even affecting the long-term treatment that our COVID syndrome patients will have? And as well, perhaps how are you planning to include practices like digital practices, telemedicine? Yes. Do you have anything to share with us? Any, innovative ideas? Let us know, please.
Yes, we have many, we could say many things, because in Italy there is a particular attention now to this syndrome. And also the government institutions are interested in it. Just today, this morning, me and the head of the doctors of our center filled a survey from the Istituto Superiore di Sanità, che sarebbe, it would be a government organization that is involved in the government of the healthcare in Italy, very important. And with this survey, they are trying to include all the facilities that has some kind of treatment towards the long COVID patients. And for example, in this survey, there was a question in which they asked about tele-rehabilitation and telemedicine. And we answered to this question saying, yes, we want to develop this kind of rehabilitation and medicine. As you know, here in Italy, after pandemic and in Europe, in all Europe countries, now we have many money. We called it the Piano Nazionale di Resilienza, ripresa e resilienza. Resilience, this word is very, very important. And in the contents of this plan, there is the telehealth that has a growing importance. So we think that this kind of situation will not end in a short term. Also because we observed that the last variation of COVID, the so-called Omicron, was lighter as infection, but was worse for the consequences. So the patients who infected with the Omicron variation has more probability to have long COVID, long-term symptoms. So we think our work in our facility, in our clinic, will go on for many times, and we want to develop other kinds of to assist our patients. One of these is surely telerehabilitation. I don't know if I answered to your question.
Thank you very much. So we've learned also that in Italy they have, you know, the specific fund for resilience. Yes. Rachel, perhaps you might want to inform them.
In Italy is a word that's so much used that I confess you that I not love so much because it is used appropriately. Is a beautiful word, is a significant word, but in Italy we have a use of this word that is not ever appropriate, and is how we can say sovraesposta.
It's overused.
Overused, and so we know resilience very, very well.
Okay, we've all overlived it, I think, because we didn't have a choice.
In fact, national plan for recovery and resilience.
At least you have the funds, Loredana. You have something, you know, to tap into and project and dream about and plan about.
Yes.
We have a very interesting comment from one of our chairs at the executive committee of the region, who is the chair of our advocacy group, Rachel, stating that the region supports your position on this generalist post and that we are all the time trying to promote it as the physios, you know, having this all-rounder sort of competencies. So thank you, Tim, for a very, very relevant comment. Also, Esther-Mary, our chair, asked to you, Rachel, do you think that COVID actually raised the profile of physiotherapists within the health sector? And how are we going to go about sustaining this profile? So what is your thought, Rachel, and perhaps even you, Loredana, you can have a go at you know, giving us your thoughts about this very important statement. Thank you.
Yes.
Sorry.
Rachel, you can go first. Thank you.
So the profile is the short answer is just to remain visible. So we became very visible during the pandemic because our skills were needed. Now, in the very beginning, the Italians told us, I have friends that are, high profile Italian physicians, and they said, these patients do not need physiotherapy. That was the message. We wrote that in the initial guidelines for intensive care management. But at the same time, in the UK, we were questioning whether the demographics of the patients would be the same in Italy as they were, in the UK as they were in Italy and in Asia. And of course, the patient demographic changed. So these patients needed a lot of physiotherapy in our intensive care units and beyond. And of course, now the second pandemic, which is long COVID. So the visibility of the workforce is already there. What we need to do is not let people forget and continue to celebrate the power of our workforce and our value. But what we need to get better at is using data to back up our value. And this is where long COVID is key, or post-COVID syndrome is key, because we know that if people have good rehabilitation, and this isn't just physiotherapy, I have to say, they will get back to work better, they will prevent further deterioration, crises, relapse, and of course, further complications of acute and chronic or long-term COVID infection. So we need to be able to add the value into language that commissioners or policymakers or managers understand. That's what we need to do. In terms of the profile, like I said, celebrated on the internet, social media, in your hospitals, nominate your teams and yourself for awards, for global awards. Don't be ever afraid of putting yourself forward, nominating yourself for an award. I have done it before. I have nominated my own teams. And when you win these awards, use that as more evidence to validate your importance. So that would be my advice.
Loredana?
I totally agree with Rachel. And our example is just what Rachel was saying. When we started this adventure, as we named it, between me and my colleagues, the doctors looked at us as me in particular, as I was a fool. No, what are you speaking of? Long COVID, what is long COVID? Great debate about assessment and how to assess these patients and so on. But I am a hard person in work, and so I go on my street, and now also the doctors are very how can I say, proud of this clinic. We have long COVID clinic. We today in the morning we had the visit of the general manager, as I was saying before to you, Maria, and the head of doctors showed her our long COVID clinic, as if it was and his creation. But I don't care, we don't care. We are interested in work and understand. It is it's very important to give evidence of our work. And this is the reason because I am stressing my colleagues to collect data and trying to go out of our clinics. Me and my staff with this long COVID clinic try to be everywhere we can in Italy. Events, conferences, webinar, because they have to know our works. So I totally agree, and we must go on because I think this is the future. Until now, we were concerned about the functional improvement, but as I said in my presentation, the future is the cognitive impairment that is very, very important and very concerning. Maybe in the future we could have more likely Alzheimer's disease due to COVID, due to this infection, because we don't know really what this infection can cause in the long term. So we have to elevate our profile. Sure, agree with Rachel, totally.
Thank you, Loredana. Very interesting, you know, global population pattern that you put here on the table. So we might even need to look into it now within the people affected who will be aging and will becoming our elderly in the future decades. So we have a very important technical question here. So I'm just going to put it on the floor, and whoever wants to go for it, including you, Marco, just let me know. So Antonis asks, do you include, and this I think is for our Italian colleagues, do you include lower limb strengthening exercises in POTS and PESC patients? And in what percentage repetition maximum do you begin with? Also, how many of the patients treated were not hospitalized? It's in our chat.
Wait.
I'll put it again in the chat if you want to see it.
Oh, yes, yes, because I don't see.
It is there. So
lower limb strengthening exercises.
And it says if your patients were hospitalized or not.
Oh, yes. Can
Sure.
Marco answer? I answer, or you answer?
I don't see the question on the screen.
Okay. I can answer. Yes, we include the lower limb exercises. In what percent repetition maximum do you begin? It's not a standard because it depends on the assessment of the single patient. We have a protocol of rehabilitation that I didn't explain because it is not worthy in this occasion, but we have a protocol that we created with a series of exercises that have the goal to improve strength in superior and lower limb, improve respiratory compliance, and in this situation I can say what is percent repetition, because I must to assess the patient, no? And on this base I can elaborate the protocol for that patient. I said it is very important, I repeat, that the program is tailored su misura. We must tailor the program for every single patient. So we can say, this is the protocol. We have a protocol, and in this protocol, first of all, we assess the patient, no? And on this base, we go to propose exercises to the patients. In some patients, we could also not propose strength exercises, because we had we could have some patients that has some problem that could worsen with strengthening exercises. So I can say in this situation, I must see the patient, assess the patient, and decide what to do with the patient, specific patient.
Loredana is emphasizing here yet again, you know, the importance of what Rachel was saying. We do not need to forget our basic generalized skills. This is basically relating to our cardiorespiratory skills with regards to us adapting a specific protocol from a prescriptive approach onto us being one-on-one with our patients, not knowing so much about the condition that we're treating, but since we know so much about vitals and how people react through their vitals when doing exercise or physical activity, we can adapt and be sort of the experts within the clinical scenario, which sometimes, you know, we have seen it being in crisis to help these patients reacting to something very new. So well done, Loredana, for that.
There is another question by this person, that is if people with long COVID were not hospitalized for COVID.
Yes, yes.
Some of them were hospitalized, some not. It is not related to this. It's not related to the severity of the acute infection. We can have, I just said, for example, the Omicron variation is a lighter infection, no? On the point of view of the infection, but is worse by the point of view of the long-term compromisation and function recovery. So it is not an indicator, the hospitalization. Some of them were hospitalized and some of them were not.
Thank you for, you know, describing this part, which is very important for us. I'm seeing a couple of comments between Esther-Mary and Rachel on the workforce planning. Very interesting bit. So my dilemma, we already had problems with workforce planning when we thought that everything was in control. What do you do in a pandemic when all the people are getting sick, all the health workforce is getting sick, people are in quarantine because a relative within the same household is sick? So Rachel, do you perhaps want to elaborate and also inform us what the British Thoracic Society is you know, compiling through the guidelines that you are working on? Thank you.
Yeah, so in the UK, we do have suggested safe staffing numbers for our critical care workforce. Sadly, they don't mean too much because not many, if any, of our intensive care units staff to that safe recommended staffing level, but they are there. Now, what we are doing for respiratory medicine, so respiratory wards and specialist respiratory areas, is working on a workforce document that looks at all of the professions that need to treat respiratory patients. And I think that's the way we have to go. So again, in the UK, we have certain guidelines for stroke and for other specialities. The kind of difficulty is for those more general conditions, like I said, we start to become a little bit exclusive for patients. So if you have a stroke or if you have major trauma, you get access to much better physiotherapy than if you are elderly or if you have a mental health condition. So we start to become very exclusive, providing rehabilitation, which again goes against our values of rehabilitation for all. But we kind of have to, we can't boil the ocean. We need to warm the puddle. So we, in terms of providing workforce numbers within specialities, hopefully that can then build for other professions and then for kind of acute wards. In the olden days in the UK, we used to have one physiotherapist for every ward in most hospitals, most big wards. or you would have one, you know, if you were the junior physio, you would have wards that were named for you. So you might have ward 5, ward 10, ward 15. And the staff knew there was a physiotherapy contact. Now, 10 years later, we just don't have that. We have teams that look after all parts of hospitals. So we need to kind of go back to basics a little bit with workforce and think about, you know, the area, the numbers of physiotherapists they have, what therapy they provide, and where the gap is. So we need to do a gap analysis of what then the needs of people that aren't met. That's kind of and of course there is some similarities across global healthcare systems, but there is also huge differences in healthcare provision as well. So how you can even start to support other countries with workforce numbers is very difficult.
Okay, thank you, Rachel. Now I would like to invite Esther-Mary to ask a question with regards to our speakers. Esther-Mary.
Thank you, Maria, and thank you to the speakers for great presentations. I actually have 2 questions. So I've one for Rachel, I've one for Loredana. So please excuse me while I indulge. So Rachel, I'm coming back to this word and to language about resilience, and I'm really conscious of our colleagues, you know, who just by nature are not resilient. And I suppose tied to compassionate leadership, but also how we support those colleagues, and that idea that I mentioned about compassion fatigue. It's just how we bring them back and how we don't lose them from the profession, because I think all of the professions have noticed a drain from respective professions since COVID. So I'd like to ask you that, and if I may just Loredana, and I suppose it's somewhat I suppose it's, you know, it's about the mental health of our physiotherapists, you know, which I think is a crucial issue that we have to address at the moment. And if I may, I would just like to ask Loredana, you mentioned about the long COVID and Omicron. I think I just missed what you said, but I just wondered if you would clarify, are you seeing a different presentation of long COVID or a stronger presentation of long COVID with patients who had Omicron as opposed to those who had Delta and the other variants? Thank you. Sorry for my long-winded questions, but thank you to both of you in advance.
Thank you, Esther-Mary. So, Rachel, would you like to start with the compassionate leadership?
Yes, that is a really quite easy question for me to answer. So things are resilient, objects are resilient, yeah, systems are resilient. Physiotherapists are humans. And what we need to remember now more than ever is the basic physiological needs of people as humans, okay, as caring, compassionate individuals who went into physiotherapy as a healthcare profession because they care for others and they want others to get better. So when we're thinking about what our team, what physiotherapists need right now, it's nurture. It's their basic physiological needs met. Now that is kindness, compassion in the sense of making things as individual as possible. How are you feeling? Do you understand what our goals are, what our values are? How do you feel about the last 2 years? Do you have fears? Do you have anxieties? Is there anything that I can do to support you? There is other physiological needs, like making sure your team and your staff have access to a kettle, to a fridge, to maybe sometimes, you know, out in the UK we find sweet treats, cake Fridays, or, you know, making sure that people have that kindness in other ways. There is flexibility in our work patterns. So if people need to take time out, if they want to come to work early, leave late, you know, adjust their working patterns, we should be encouraging that for people's health and well-being. If people are coming to work and having a real, you know, we have the red, amber, green days. So people come into work, I'm on a green day today, I'm feeling really good. I'm on an amber day, I'm not so good today. Maybe someone can check in with me. And I have a red day, so this is a day where I feel really, really low. I don't know if I can get through the day. I'm feeling really stressed or anxious. That's a day where you might say, okay, what can I do to make your day better? Maybe working from home if you can, or working with more people in a team so you're not working alone and you have that team support. And then, of course, reinforcing to your team about how well they've done, especially when you may have 40 people to see in one day. That's unrealistic. So helping people to prioritize and then making sure they don't feel like they failed at the end of the day or they haven't been able to do enough, because nothing will be enough in pandemic or as we recover from pandemic. But what we have to do is do things well and look after each other. And that's a really important point of the recovery phase we're in now, while we're still seeing across the world huge numbers of COVID infections still. So my advice is to always check in with each other. You know, when you think of the leader you want to see is the leader you want to be. So the things that you do for people are the things that you would expect or you would appreciate yourself. They're not difficult. It's not putting people on courses. It's not giving people, you know, token gestures. It's just those simple things that people really value that are priceless.
Thank you, Rachel. Thank you. Thank you, Esther-Mary, for your question. Thank you, Rachel, for a very valuable answer. Loredana, it's the last contribution, and then we start concluding.
I want to say only one thing about it,
yes?
because as a leader of a team, we have the duty to care about the staff, and I try, Marco can witness this, I try to be a kind leader, and I care many of their well-being. They know, and they I say to all of them, my door is ever open to say everything. With regard, you agree?
Yeah.
With regard about the questions from Esther-Mary, I meant that the long COVID from the Omicron variation presents stronger than the previous variation. It is stronger, yes. It is stronger and longer. Longer.
I agree, Loredana, I agree with you. So, dear all, it's time to conclude. I thank you all for attending today's event. A special thanks goes to our technical team, Aitor and Miguel, who are fabulous. You know, we have just a super team of, you know, IT experts that are constantly assisting us, especially me and Ono in IT. So thank you guys, I really appreciate your help. I wish to thank our speakers for today. Thank you for being here. I wish to spare my best wishes to Anne, who wasn't with us today. Also, a great opportunity through World Federation of Public Health Association. So the physios were here in this amazing celebration. Thanks to our inspiring speakers, I am surely having a green day, as Rachel rightly said. My take-home message, I got a bit of what Rachel said and a bit of what Loredana said. Systems are resilient, but physios and human beings have their basic and physiological needs, and we need to take care of our members of staff, which also makes me want to spare a quiet moment, a couple of seconds, to think about our colleagues and patients from Ukraine who are passing through so much right now.
Thank you.
I thank you all and I wish you all a good evening. Saha, thank you. Bye.
Bye.
Thank you.